Welcome to our first virtual gathering of Celebrate Sisterhood. In this online educational series, we will discuss ways to keep you and your family safe, healthy, and thriving during today's pandemic. We hope you enjoy this unique program designed especially for you. Thank you for being part of our Cleveland Clinic family.
Hello everyone, I'm Dr. Linda Bradley, founder and chairwoman of Cleveland Clinic Celebrate Sisterhood. This is a community outreach and education program that empowers multicultural women to embrace self-care and to strive for optimal health for themselves, their families, and their communities. And today it's my pleasure to welcome you to the first edition of our virtual education series, Celebrate Sisterhood 2.0. This event is pre-recorded. If you have any questions about the information shared today, please email us at celebratesisterhood@ccf.org. My guests today are Dr. Stephen Gordon, Chair of the Department of Infectious Disease at Cleveland Clinic, and Dr. Joy S. Copeland, an attending dentist at MetroHealth System and a COVID-19 survivor. Today's topic is Living with COVID-19, Pivot to Recovery. Welcome, Dr. Gordon and Dr. Copeland, for joining us.
It's a pleasure to be here, Linda, and a pleasure to share the stage with you and Dr. Copeland.
Yes, it's a pleasure to share my story and to share the platform with you all.
Thank you so much. So what are we going to do today? What's our goal? Today we're going to get an update about COVID, how it starts, its epidemiology, how to be prepared in meeting the demands for COVID as a clinician. We're also going to pivot and look at mindfulness, how to take care of ourselves and how do we reflect upon this pandemic. And most importantly, what is our way forward towards recovery? So what I'm going to do is to start with Dr. Gordon and just ask you, what is COVID?
So Linda, thank you. So, COVID is the disease. This is a coronavirus. It's COVID-19 because it was identified at the end of 2019, caused by a virus, which is coronavirus. We have been infected with different types of coronavirus in the past. This one's a little bit different because one, it's new. Two, it does come from an animal, most likely, obviously, bats. Three is we have no immunity to it. And four, obviously, this rapidly has spread from the nidus in a place called Wuhan, China, obviously across the globe in less than 6 months. And if you're writing a kind of a bioterrorism novel, this has got all the features. And so that is kind of where we have been. And now, of course, I think we've moved from the phase of the initial brunt of the infection, obviously in the States and worldwide. And now moving toward, as you stated, is how do we move forward, understanding that there will be no vaccine, at least for another year. So we're going to be in this, what we call pre-protective phase. The second thing is that we still have no reliable test of blood to establish who is actually immune and not immune. And the third thing I think is that we also know that we can only shelter in home, which was a great thing that was done here in Ohio and across America for so long. And so again, as I think this is beginning to think of emerging, but how do we do so, not so much eliminating risk, but mitigating risk?
Excellent. Many of us know about other re-emerging viruses. Tell us a little bit about measles and anthrax. How do you put that into perspective? Those viruses compared to COVID?
COVID. So I think, COVID is primarily, we think about as a respiratory disease, similar in a lot of ways to influenza. That's the biggest spread, very effective person to person. We estimate that for every infected person with COVID, without any other protections of distancing, masking, that about 2 to 3 other people will get infected. Not everyone is going to get severe disease. In fact, most people don't require hospitalization or medical care. But we do know, obviously, there's a certain segment of our population where that's not true. And if we look at America, it really is the elderly has taken the disproportionate brunt with underlying diseases. But although long-term care facility patients maybe represent 11% of the population, it's over a third of the deaths. And in Ohio, it's up to 3/4 of the deaths have been in this, what we'd say, vulnerable population. It is not like Ebola, meaning it's not a wet disease, and it's not as contagious as things like measles. But nonetheless, it is, as we all know, because it's a novel, that is a new virus without any pre-existing immunity amongst humans, that it has really spread and can cause a lot of morbidity in terms of many of our population.
So how do these diseases emerge? What's the driver for some of this?
So it's a great question. So if we look at what I'd say new and emerging diseases in the past 50 years, most are diseases of animals. We think about this, a lot of the drivers are human action. So whether it's encroachment on the rainforest, whether it's global warming, whether it's also things of living closer to animals or animal husbandry. So for instance, in Wuhan, the wet markets, so you have live animals living together. And this is not the first time we've seen that, what we call jump. I mean, we remember Middle Eastern respiratory syndrome from camels. We remember severe acute respiratory syndrome, SARS-1, also coming from civets, also a bat origin. And if we look at a lot of the diseases, historically have been diseases of animals that kind of transferred over to humans, and then they become a little bit more moderate over time. So again, this is not unusual per se, and this is really a hotbed of research and surveillance, and it is why, for instance, even after the flu pandemic, the H1N1 we talked about, or the avian influenza, that the World Health Organization, CDC, have set up surveillance for new and emerging infections across the globe because it is everyone's issue. It's not just a Korean issue, a Chinese issue. As we know in this era of mass kind of supersonic travel, we do need to worry about flu and cough that may be occurring in China because, as we now see, that can come to America, the homeland, very quickly.
How did it get here in the first place? And how is it continuing to spread?
So it's another great question. So that story is being unfolded, but it's clear that there was a respiratory issue going on in China in the fall. It may be even sooner than December. The first report, if you remember, came out right at the new year, where is about 50 cases in Wuhan. And the sequencing that is taking that virus, identifying it, being able to grow it, and sequencing was done within a couple weeks. Based on the sequencing, we now believe that many of the importations in the States did come from people who were either inapparent infected or incubating the virus from both Europe and both Asia. And again, if you look at the immigration patterns, I think it's like 450,000 people came to the States after President Trump put in the kind of no Chinese fly order. A lot of those were Americans. And you can begin to see how that this could have spread into the States, not necessarily intentionally. And the other interesting thing is we know that it came in on the coast, right? New York as well, mostly European strains, but not all. But we also know there was a diaspora of about 400,000 New Yorkers that left New York before the lockdown going to other parts of America. So again, in a free and emerging societies, you can see how things can spread quite rapidly, not with intention per se. And that is the situation I think that we're in now.
And I think your point about New Yorkers leaving, I thought it was very interesting to see how our cell phones can be tracked. And they could actually, I think it was over 400,000 New Yorkers left New York to go other places. So our cell phone has a lot of information that we can follow individuals. And I just thought that that was an interesting story. So where are we right now, Steve, in terms of numbers of cases worldwide? I know this changes every day, but what would you want our listeners today and viewers to know about as of this week?
So I would say that right now we are still in a situation of flux. So in the States, obviously, there are still what we call hotspots. Most of those are now located west of the Mississippi, places such as Texas and Arizona. But if you look at the numbers, it's still over 20,000 new cases a day. The death rate has fallen, that is true, but we are far from over in terms of containment. Stepping back globally, you might have even heard on the news today in Islamabad. So the new hot areas are obviously South America, in parts of Brazil, if you look at parts of Chile, Ecuador, and now obviously India and Pakistan. And of course, even in Beijing now, you see a little bit of resurgence. So we are far from over in terms of containment. And this is something that we are probably going to have to continue to live with, so to speak, and come up with different ways of what we would say mitigating risk. Especially, I know it's difficult to think about that, but in a few months we'll be in cold and flu season again.
Yes.
And that's kind of the double whammy. We've talked about the second wave, but I think as Dr. Fauci points out, we're not through the first wave yet. I mean, I think which is very, very true. And so just stay tuned.
So when you look at two other diseases such as SARS or MERS, how quickly does that spread compared to COVID?
That's a great question. So again, the coronaviruses get their name again because of RNA viruses and a little bit of spikes on top, which give them that crown look. And again, these are two other coronaviruses, the MERS and the SARS. Interesting, SARS, SARS also caused acute respiratory syndrome primarily, a lot of associated deaths. There was a diaspora that went to Toronto, and all of a sudden it went away. And we still don't know the reason for that. MERS, on the other hand, Middle Eastern Respiratory Syndrome, associated with camels, is still endemic in that area. Also very high death rates, but it has not spread outside of that area, but it's still something in that part of the world that people kind of are very much surveillance. So our estimates on this coronavirus is, although it may disappear, none of us think that that's the case. It may morph into something a little bit less aggressive, but we do believe that we are going to be in for a coronavirus as part of our platform for acute respiratory illness for many months and potentially years to come.
Yeah, I think it's pretty fascinating that you look at SARS, it took 8 months to infect 8,000 people. But for COVID, my gosh, 8 weeks to infect 80,000. And for MERS, 12 months rather, to infect 108. So as you said, it spreads with great velocity. And some of the things that we're going to later talk about tell us the things that we're going to need to do to decrease the velocity of spread. So let's just first look at, we've learned about the disease, where it's come from, how the numbers have grown. Let's just look at the clinical spectrum. So Steve, as a clinician, an expert in this, what are some of the clinical features that are hallmarks of the disease that you've seen?
So let me start by saying I've been humbled by this virus. That is to say, the myriad presentations that we're learning about continue to kind of make me very humble in terms of what it can and cannot do. Of course, the initial presentations were the sickest patients going to hospital, primarily with an acute lung injury. So this would be the classic signs: fever, shortness of breath, with what we'd call shadows images on chest x-rays or CTs, very sick patients. But as testing progressed and extended outside of this cohort, there were other associations noted. And again, in younger people, for instance, that new loss of smell or taste is actually very highly associated these days with COVID infection.
Did you remember this very much from med school, the sense of loss of taste and smell with other viruses? I've been trying to rack my brain to say, is that something we had to memorize or learn years ago? What do you recall? Because I thought that was a very interesting new symptom.
Yes.
Can you tell us more about that?
So it's not specific, obviously, for COVID, but I think when you're talking about millions and millions of people being infected, then syndrome patterns emerge, and this is certainly one of them. It doesn't mean that you have COVID if you have acute loss of smell or taste or other things that can do that. But in a pandemic, very, very highly specific, especially in younger people. Again, there's been diarrhea syndromes associated with this, fatigue syndromes. And so I think the book is not written yet on the full spectrum. And as you know, in OBGYN, in a pandemic, you also have the issue of pregnant women. And at one point in the height in parts of New York, about 13% or so of women coming in to deliver had evidence of recent or past infection. And again, the other part of this is we were taught initially that kids probably were infected but didn't get a lot of disease. It's rare to have seen children hospitalized. But as everyone now knows, there's a new kind of multi-inflammatory syndrome that's been described, first in the UK, now several hundred cases in the US, similar to the Kawasaki's.
What does it look like? What does it look like? So if a mom is watching this, if you're going to send your kid to summer camp, what are the camp counselors looking for children in particular?
So the two age groups, but when we talk about it, it's usually going to be a syndrome of usually fevers with skin lesions, looking for also the raspberry tongue in terms of this nature. But again, as a syndrome, it is a myriad, there is all sorts of things and nothing quite specific, but it now is in the differential. And generally speaking, evidence of COVID may have already been gone. So it's thought to be potentially a post-viral type of syndrome, not specific to COVID again, but again, truly associated. The other thing I think that has come up is, can I get it from my pets or pets as a pet lover? So it is true that there have been some cases that cats probably can get it, but there has been no identified transmission to humans in that regard. So it's no reason to get rid of your pet, so to speak.
Okay, very good. And what is the case fatality rate? How likely is it someone to actually die from this disease?
Another great question, Linda. So the case fatality is really wrapped primarily around the acute lung injury in patients with underlying comorbidities. So when we look at case mortality rates, say even in the clinic, in the ICU here, we haven't had anyone, I think, less than 50 die. All the deaths are going to be age associated. And of course, with age is also underlying conditions such as heart disease, underlying lung disease, and again, requiring often what we would say ventilation and things of this nature. So that is, even in what we'd say acute respiratory distress from anything, the associated mortality can be up to 15 to 20%. And so that's not unusual, but once you get to that stage with COVID, very associated relatively high mortality rates.
So let's kind of summarize for our listeners. I think I know many of these, but if I miss something, let me know. Sometimes fever, headache, diarrhea, fatigue, possibly loss of smell or taste. Anything else that you would want our listeners and viewers to remember in terms of symptom complex?
No, and as you stated, these are very nonspecific, but when should you be alarmed or call the physician? So these would be obviously people where you have new chest discomfort, more shortness of breath, difficulty breathing, or change in terms of awareness. And that would be true for any type of undefined illness. And of course, we really worry about those people with underlying conditions that may make them at higher risk, not for acquisition, because that's the same for all of us, but for complications. And that is somewhat age-related in things. And these are things that we really want to educate everyone about potential risk to family members, household members, in terms of what you can do to try to mitigate that.
Excellent. And I'd like now to turn to Dr. Joy Copeland, who's a dentist. We've introduced her earlier. And I'd like, if you wouldn't mind, sharing your journey. You are a COVID survivor. And I'd like to just hear from you. What were your symptoms? How did you present? What's been your journey?
Well, first, I would say I noticed that I was having symptoms towards the end of March, but they weren't specific because I was actually very sick for a while. I had gotten sick in the middle of February with what we thought was something.
Like what type of symptoms? What type of symptoms?
I had a sore throat. Initially, it started with a sore throat that progressed very rapidly to chest congestion and nasal congestion and shortness of breath to the point where I had a difficult time moving from my car to my house. So just walking, I became very labored. But at that time, in early February, no one was testing for COVID, and my symptoms did not match or align with what they were discussing with the dry cough. So no one ever decided to test at that time, but I continued to stay sick. I was on several different medications, several different steroid therapies, but nothing was working. I was not getting better. I was just getting worse.
Excuse me.
I would cough and I would vomit. It was a very forceful cough that I had. So it just never got better. But as time progressed and the end of March started to approach, I noticed that I was feeling hot. And I noticed I have a young baby. I have a 1-year-old. And I was trying to carry her upstairs in our home, which is normal for us. So I shouldn't be labored. But I just remember distinctly that weekend trying to go up the stairs and felt completely exhausted when I got up to the top of the stairway. And I just noticed I was hot. But in our in the area of Cleveland at that time, the temperature was around 40 degrees. So it was fairly cool or cold to some people, but I shouldn't be sweating in my house.
Right.
So I knew something was wrong, but I just didn't think that it was anything else because what we just thought was it's some type of virus. We just don't know. I had a chest x-ray done early February and they said everything was clear. So we didn't progress with any other treatment other than things just to make me feel better at that point. But once I noticed that I was hot towards the end of March, I decided the next day, well, let me see if this is a fever, because I'm just not feeling well. So I took my temperature and it was 102.9.
Wow.
So I was alarmed at that time. And at that time, we knew a little bit more about COVID and testing had started in Ohio at that point. So I alerted my primary care physician on the Monday. So it was a weekend. So I noticed symptoms Saturday with the fever. So I called the doctors on Monday morning to alert her that there's a change. Something has changed. I have a fever. I'm not used to having fever. So this was out of the ordinary for me. And I just described to her my symptoms that I had. And at that time, it was just a fever and sweating. And then the other symptoms that I already had with the wet chest, the nasal congestion, and the forceful cough.
Did you by any chance take, as a physician, know about using a pulse oximeter?
Yes.
Did you buy one or have one?
I had one sent to me. My mother sent it to me because I have a chronic condition. I have asthma. Okay. So in my mind, I wanted to make sure I didn't progress to a pneumonia once I found out that I had COVID. So once I got diagnosed, I knew I had a game plan in my mind of what to do because I saw what it was doing to other people. And to prevent myself, because I already have chest congestion, I don't need it to progress further down into a pneumonia. So I had a pulse oximeter. I had a spirometer to check my lung capacity. Okay, excellent. So I had those things in my possession once I did know that I had COVID. Okay. So did you find yourself needing to go to the emergency room or get admitted to the hospital? No. So what was explained to me once I got the diagnosis, it was you only go to the hospital if you cannot talk and breathe at the same time. Okay. All right. So it never got that bad for me, but it was enough to keep me in the bed at home, knowing I couldn't do anything. Okay. Excellent. Excellent. We'll get back with you in a minute to learn a little bit more about your story. I'm going to return, but excellent. I think you've handled these questions very well. I think you've given us a lot of good information. And most importantly, I'll say it now, I'm so glad that you're back to work, that you look great, and that you feel better, and that you're telling your story. So thank you with that. I'm going to go back to Steve for just a moment. We began to talk a little bit about some of the health conditions that put patients at increased risk. Dr. Copeland just mentioned the issue of asthma. Tell us sort of in rank order what kinds of things put patients at increased risk for developing COVID.
So again, I want to separate the risk for COVID from, that's going to be the transmission issues in terms of how that's transmitted. And again, whether you're young or whether you're old or have under conditions, those are going to be the same. And so prevention of transmission or risk of transmission, what we talk about now is stay away from indoor crowded areas, right? In terms of that, obviously try to social distance. That would be another situation for prevention. And as we said now, avoiding the big crowds. So many of us now have a congregation of a COVID community, but still trying to get less than 10 people per se. But the other thing I would say, and I'm listening to Dr. Copeland, is the other area you got to look at is your household. Because as we talked about, even though she's a healthcare provider and maybe she was exposed from a patient or things of this nature, the biggest risk for transmission is in the household. And that's because that's whom we're spending most of our time. It's thought, again, you need at least 15 minutes of close airspace with someone that is infected with or without symptoms. And for many of us, we're at home, we're not wearing masks or things. And so it is the household members, not to look at with a jaundiced eye, but these are the things as people have now opened up, the kids going out, is to be very cautious about your own household in terms of vigilant for symptoms. And again, separation if there are symptoms. In terms of who's at risk, Linda, I think interesting. So we talk about now, COVID does not affect all populations equally, even after infection. Many of us have seen what we call in many cities associations of hospitalization, not necessarily death, with what we call other factors. And CDC just published a study yesterday looking at Atlanta, who's hospitalized, who's not with COVID. And again, the risk factors that came out were age over 65 and being African-American. Now, when they stratified for underlying things that you talked about, heart disease, lung disease, those two still came out. And we don't believe there's a biologic predisposition for being a person of color, but it does then raise the question, why is that? And what is it? Is it that people don't have access to earlier outpatient diagnosis or management? Is it the fact that maybe in the household there are more people whom are at risk for bringing COVID into the households of some of these people? Because you got to remember, if you're older than 65, most likely you're not a frontline worker per se anymore, and most likely you're not necessarily taking mass transit all the way. So as you know, this has been a very important area of research in terms of how can I say this, equity issues in looking across our healthcare system with honesty in saying, wait a minute, there are things that COVID has uncovered that we need to improve. You know, I look at Dr. Copeland, she had access to care and but was her own advocate there in terms of here. Many people were told, hey, don't come to the hospital, don't come to the ER. So this is still being unraveled, I think, and very important for us to do the postmortem. How can we improve? How can we have more equitable delivery of our healthcare services?
Can you tell us a little bit about what's happening at the Cleveland Clinic as it relates to things that we're doing to address some of the racial disparities that you just alluded to?
So I think it's great. Our data also shows that persons of color and African American is not a risk factor for death, but is a risk factor for increased hospitalization. And by also looking at zip codes, looking at other underlying aspects. And so again, there is a big push here to try to look at that data, to try to, again, the community of health. I think Dr. Mihaljevic, our CEO, has made this a big priority as well. Beyond COVID, in terms of prevention aspects, education, as well as, of course, trying to be sure that we would much rather prevent a case of COVID than treat a case of COVID.
Another thing that I would just add are a few things that I know about. We're doing walking programs with Celebrate Sisterhood as soon as our infectious disease folks tell us that we can resume. The men's minority health fair was suspended, but lots of information. It's good for the community to know that soon, to be determined in the not near future, will be a new community store. Myers will be coming to our main campus community. So I think we're looking at also increased access through Langston Hughes for primary care. So I do want to point out that the Cleveland Clinic has really taken a big step pivoting to really look at these essential things that our patients need who may have cardiovascular disease, hypertension, malignancy, other respiratory problems that could be associated with increasing some of their risk. So, and certainly having great doctors to address our presentation and to listen is going to be very, very important. So I think we're doing a lot. We still have many more miles to go before we sleep. but I do think that the clinic is addressing some of these things that you mentioned. So the other thing that I've noticed, and I'd like to see what you think about it, and I'm glad that the hospitals are opening. I would like to say now there's lots of commercials to say that the hospitals are safe. As a surgeon, all of our patients are getting COVID testing before surgery. But I also noted that because the hospitals had been closed, some of my patients had deferred treatments, not even treatment, but diagnostic testing. What might they be? Mammograms, Pap tests, getting their bone density, getting refills for medication. What are some of the things that you have noticed, or that other disease states that have been potentially affected because of fear for not coming in to see a doctor or coming into the hospital? Are there others?
Yeah, so Linda, you make up great points. So if we looked at, for instance, New Jersey and New York, looking at mortality, yes, there was a lot of mortality attributed to COVID, but there was also mortality attributed higher than expected. And a lot of that was most likely due to unattended heart disease or strokes, or potentially, as you said, surveillance for cancer. Patients got two messages. Initially was don't come to the ER, and then many were maybe afraid to come to the hospital. And we noted even here a marked drop in strokes, heart attacks, in new cancer diagnosis. And of course, these things didn't just go away the past 3 months. This was obviously behavior and surveillance. Now, I do think the other positives here are what we've also learned is we can deliver healthcare without necessarily a patient coming in front of us. I mean, I was always taught, and Linda was, that, you got to touch hands-on, and we believe that. That's true. On the other hand, this has forced us, I think, in a good way, to meet patients where they are. And many of this can be very efficient and effective in terms of access to getting a hold of your provider. And you can still make some good assessments, keep the ball rolling, so to speak, without having patients come down necessarily for a variety of reasons. So I think we'll have a level setting there, and I think that's a win-win for providers as well as for our patients.
Right, and I could expand on this as a OBGYN physician. Our patients can now reach us through telemedicine, and that's the old-fashioned telephone as well as video conferencing. So I would like to just let our listeners and viewers know that really don't have fear to come to the hospital. Please come in if you have symptoms. The hospital is safe. We're going to talk a little bit about personal protective equipment and masks in a moment. But let's get back to seeing your physician, your healthcare provider, your nurse practitioner to make sure some of the very basic needs that you may have are taken care of. We're here to serve. We're starting to have more evening hours, weekend hours, soon to be announced, so that we can get back and make sure we're servicing the needs of our patients. And our hospital is ready for you and has always been ready, but definitely want to put the message out that we're ready now. I want to just ask you, Steve, again, I want to just make sure we've got this covered. Social determinants of COVID. Tell me one more time, summarize that a little bit more for me so that we make sure we're clear on that. What does that mean, the social determinants of COVID?
So when we talk about social determinants, as much of the audience knows, these are things that are kind of your environment. And a lot of it is determined by zip code. And so are you in, I know Dr. Bradley's got a big issue in terms of food deserts. What is available to you? Is your environment around a safe environment from either a pollution or noise level? What is your access in terms of, your schools, safety, things of this nature, in all of this, let alone crowding. So it's much easier for, say, people in Chagrin Falls to isolate if they have a spacious, spaces, as opposed to if you have a lot of crowding in a relatively small apartment. And these are things that actually probably do matter in more ways than we think about. And I think these are for physicians like Dr. Bradley, and I'm sure Dr. Copeland, you go beyond just looking at the vital signs. This is these relationships that you want, and for us to actually try to put patients in a position to succeed despite the environments, and advocating for what we call non-pharmacologic interventions in terms of for our patients in our communities. And it pays dividends, because the clinic, for instance, we want talent. We need people in a healthcare field. Look at me, I'm old. I need younger people here. And we're going to get most of our talent locally. I mean, we want to actually promote our communities. These are our providers, and we need people in IT. We need these programs. And perhaps Dr. Bradley can talk about, there's been a suspension of some of the internship programs, but these are important. As Dr. Copeland knows, we need mentors. We need opportunities for all of our population.
Excellent. And I will mention that at the end of this. Those are really good points. So thank you again for bringing those up, Steve. Many women know about the GAIL model, G-A-I-L model, that we use for breast cancer risk factors. I saw, Dr. Gordon, that the Cleveland Clinic is using an online risk calculator to sort of stratify different risk factors for patients. Can you tell what we're doing? So if a patient comes in to the hospital, how do you use, what is the online risk calculator? What things are you keying into it? And telling, even if you have the same symptoms, but just look at the race and also the gender, how that may change. I just thought that was very interesting. I knew we did that for breast cancer, but I did not know much about it for COVID. So tell us a little bit about that.
So this was done on the first 11,000 patients. So things have changed because the epidemic changes in terms of whether people are doing exposures and social distancing. But it was interesting to note, as you stated, that zip code alone was a big predictor, and you just change a zip code and potentially a race, and you might have the same underlying factors, but your potential risk of testing positive for COVID would significantly differ. Now, remember, we're in a different time. This changes all the time now. More testing, more awareness, social distancing, and things like that. But I think this gets to your underlying point, is that we are not all affected equally by any type of disease that crosses the population. And these are some of the factors. And as you know, testing, and Dr. Copeland mentioned that, even though she knew about COVID in February, she couldn't get access to a test. And that's important as well as we try to move forward as well. Not just testing those that are sick, but for instance, doing the contact tracing in the households, or doing people such as we're doing preoperatively, even with no symptoms, for a sense of security.
What would you consider, Steve, a dangerous mix of activities? What should we be avoiding right now? And then I'm going to have Dr. Copeland to think about that in a moment and come to her in a minute. But what's a dangerous mix?
The dangerous mixes, and again, a lot of these are these nice little outbreak investigations that the CDC has published over the last 2 months. So congregate activities that are indoors. So the sine qua non would be obviously either a cruise ship or a military ship where there's been huge outbreaks. You've got a lot of people where actually mixing is encouraged, right? I haven't been on a cruise, but I don't think you want to spend time in your room. You're out there mixing it up with others in terms of this. And this is ripe, obviously, for a respiratory virus to be transmitted. Similarly, though, we've also seen outbreaks in choirs. Indoor, you can think about singing as kind of another way to potentially spread or emit a respiratory. So we don't like that types of activities indoors. Maybe the analogy is going to a Cavs game and yelling. And you can see why people are a little bit nervous about that big congregate activity. The other thing I would say is, of course, is outdoors is much safer in general. We say the solution is dilution. So opening the windows, eating outdoors is probably a much safer environment. It's not to say you can't get transmission, but we like that. And now that it's warmer here, and then that gets to the face protection. And why we say wear a cloth covering when you're out and about is, again, to protect others, obviously, from maybe you spreading something that you don't know you have or don't have symptoms yet, but it's paying it forward and other people as well. So these are the cloth masks that you can just make from a T-shirt, different than the surgical mask that Dr. Bradley or Dr. Copeland wears. And I'm sure if we talk to Dr. Copeland, she's always worn eye protection and a surgical mask as she's in your mouth, even before COVID. The dentists really know about infection prevention, which is great. And that is now for us, if you come to the hospitals now, it's a different experience for the patients and limiting visitors, but also for us, the providers. So you should see us wearing our cloth mask when we're in the public spaces. and then appropriate, what we'd say, PPE as we enter the patient's rooms.
Excellent. And I'd like to just ask Dr. Copeland a few questions. So how have you, the information about a dangerous mix, now that it's spring, moving into summer, as a COVID survivor, how have you utilized these new spaces? What are you finding yourself and your family doing? You have a new baby. I think you said she's 1 or almost turning 1. How are you using the information to stay safe and also for your family?
Some of the activities that we normally would do during this season, we have kind of put a pause on those until we feel like the numbers have gone down significantly. I feel that even though a lot of different venues have opened, the virus is still here. And so we're kind of forgetting that it's here. And so I have gone to places of business for food, to pick up food, and have noticed that everyone in the restaurant has no mask on. I was just completely baffled by that, that people think it's safe just because it's open, that there is no risk. So what we do is my daughter is too young to wear a mask. So what we do is we don't allow her to go into public places where she may encounter multiple people in a tight area. So I don't take her to the store. We have to alternate trips for those things. She does go to daycare. Daycare has drastically changed. At least the one that she goes to, they have drastically changed their protocols. So the children are tested before they even enter the door. The adults can't enter the door. So there are a lot of precautions that they have changed. But there are some places that I just, at this moment, refuse to go into because I know the risk. So places like a gym, I don't understand how they have changed their protocols at this point to prevent transmission. I can't see myself doing a heavy workout wearing a mask. So I don't think a lot of people will do the same. Going to church, because we know we'll sit close. That's not somewhere I would venture into right now. And also things that I normally would do now. So right now, my birthday is this weekend.
Okay.
I would normally have a party.
Okay. So how are you going to celebrate this year?
So we are changing it to, it's just intimate with my immediate family. And we're doing it outside on our patio. We're just going to grill food. It's just small, it's intimate. We're still going to celebrate, but we're not going to go to a facility. We're taking it outdoors so that we can be distanced from each other. And also, we're still going to wear a mask until we're eating.
Right, right. Okay. Those are all very practical and wise decisions for you and your family. Thanks for sharing that with us. I'm going to get back to Steve and ask him for an example of something. What is cough etiquette? How do you do it? How should we do it? And I'd like you to show us how you do it.
So cough etiquette came out of the last pandemic, the H1N1. So this was influenza, which spread across. And this is something CDC came up with. So they realized, again, a respiratory virus that spreads. The concept was, although they didn't say universal masking like they've gone in terms of COVID, but the point is we know that it's spread by mostly secretions from our nose and our mouth, so that if all of a sudden you're in public and you're sneezing or coughing and you don't have a Kleenex there, it would be so either into your sleeve or covering that is kind of what we'd say cough etiquette. If we think about the masking, that's kind of cough etiquette elevated a little bit, because if I sneeze with my mask on, obviously, that's one of the purposes of having that barrier. And so I think this will evolve. I mean, we are also looking at the shields, and shields have another advantage, I think, in terms of for servers at point of service. People do like to see people's face and eyes, and people are looking at that as a potential another alternative in terms of a way for protection, but also kind of living a little bit more with COVID. But I just think it's also interesting if we look at Dr. Copeland. So she had COVID, and you can see we still don't know whether you quote unquote get it a second time. For most of the people, we think they're immune. didn't get intimate, but I suspect her 1-year-old was with Dr. Copeland for a long time, before the diagnosis, and she may or may not have also been infected and exposed, which is fine. So I think these are unanswered questions, but what I would say to Joy and obviously Linda is there is some now individual choice of risk assessment. And we don't want to judge people for what they do or don't do, but we also want to leave a pathway for those that want to be what I would say much more conservative or risk averse to make sure that that is in place. And in the clinic, in our workspaces, we are making sure that 2 meter, the masking, the issue about avoiding crowding or counting to make sure that we don't have a lot of patients overflowing in our waiting rooms. It's important that we make all people feel comfortable.
Excellent.
Having said that, my dad's turning 90 next weekend, and I haven't seen them in 3 or 4 months. They're well, they've been home, but we made our own decision in terms of, let me go, I want to see them. I want to visit with them.
Right.
And I think these are individual choices without judgment, but as long as they're made in terms of people understanding, I think that that's okay. We have to accept that as things move forward. Because like I said, we're not going to be in a level of protection for probably another year. We're not going to have that quote unquote herd immunity. If you estimate in Cleveland, it's probably less than 6% of Clevelanders have been exposed to COVID. When we talk about community protection, these are levels 60, 70%. So there's still a lot of people who are not immune to COVID, as Dr. Copeland said, who are still at risk of getting COVID.
Absolutely. We had a couple of questions earlier that have been sent to me. Folks want to know, what is an N95 mask? How does it compare to the face masks that our kids are making? Just tell us a little bit about that. And who needs it?
So the 3 different mask types we talk about, and we'll leave shields off the table. One is the cloth mask. And again, that's a barrier mask that I wear out in public spaces if I anticipate, seeing people. And again, that's me protecting you from me. And if all of us do that, it pays it forward. The disadvantages for those that wear cloth masks know, you can't breathe through it. It's not form-fitting, but you're breathing around it. And so it's not necessarily something that's durable for a long period of time. The surgical face mask, which you are both aware, works differently. There is the fiber, it's got an ionic barrier, but the one thing you notice when you put these loop masks on is you can breathe through them. Now, they're not form-fitting so that you can still breathe through the sides, but you can breathe through that surgical loop mask, and you can wear that for a long time during the day, much more comfortable breathing through. N95 is form-fitting. By definition, it's a respirator, and this is used not just in medical, but also in environmental, where there could be other type of breathable toxins. You need to be tested for that. But when you put the N95 on, again, it's tight-fitting, and if you wear that for a long time, you'll get what we call N95 nose.
Yes.
And again, it's not made to wear for a long, long period of time. So each has its indications and its utilizations. We use N95s when we talk about aerosolized particles. That's a different debate. That's like a TB. And that is also when we talk about COVID or influenza, doing things that may cause intubations or things, someone to aerosolize.
Yeah, let me ask Dr. Copeland, as a dentist, if you look at your practice now compared to when you were in training or last year, how are you keeping safe and keeping patients safe in your office? What's different for you as a physician, dentist?
Well, in dentistry, it's already customary to wear a certain level of personal protective equipment. So wearing a mask, a surgical mask, and eye protection. So if you wear eyeglasses, you wear shields on the sides of the glasses. And also in my practice, we wear disposable gowns. Everything we do is kind of disposable. So we wear disposable plastic gowns that are impermeable to fluids. But what's changed now is a face shield in addition to everything else. If I had it in my office, I would show you, but I don't have it with me. Okay. A face shield that's clear, that's see-through. That's another layer. And also when we are in our clinical office, we wear an N95 throughout the entire office all day.
Okay, excellent.
So we wear it all day.
Okay.
Because we have a large practice, we have a training facility. So there's always someone in the office that is kicking up aerosols in the air. So we have to protect ourselves because we're always in that environment that we wear an N95, because it's not only protecting you from me, but I need protection as well. So that is the point of the N95. So we wear the shield in addition to the N95 mask and, hair coverings.
Okay.
Because of the aerosols, this is a little bit different than if you're going to see a patient that we're not doing a procedure. More than likely, you're not going to wear a hair covering, but because we're in that environment all day, I have a hair covering, which is a scrub cap or some type of bouffant that we wear in addition, and also foot coverings on our shoes. So shoes and clothing that we wear when we're in treatment does not go home. It stays at the practice. So there are things that we're doing now to try to prevent transmission to our family members.
Excellent.
Once we leave the practice. Mm-hmm. Some of the protocols that we've changed in the practice for the patients, we have drastically reduced the number of patients we see per day, per provider, per space. So there's no one adjacent to me. That's a lot of space in the office. So we drastically reduced the number of patients. And also we have asked patients to arrive at their appointment time. Some patients had a tradition of showing up a few hours early and just hanging around in the waiting area, but we ask that they not do that anymore, so that it reduces the number of patients sitting in the waiting space. I do practice in a large hospital, so they do have other places that they can go, but if they are going to stay in the waiting area, we only ask that the patient being treated come to the appointment, or if that's not feasible, they can come, but they cannot come back to the treatment space, just for their own personal safety.
And I want to ask Dr. Gordon, if we look at the Cleveland Clinic, it's going to look different. If someone had an appointment a year ago in the A building or any of our buildings, it's going to look different. Just let the audience know what hospitals are looking like, whether you're coming to see a doctor in a clinic, much like Dr. Copeland mentioned. What would someone see now, if you can just briefly tell us?
So again, we are trying to limit, obviously, what we'd say non-essential people coming in. For a while, we had a very restrictive no visitor policy except for exceptions. That has been loosened up a little bit, but still restricted. Every patient coming in is going to get thermal scanned in terms of temperature taken. Same thing with employees as well. And then hand hygiene out there, and also questioned. As you go to your appointments, you're going to see now, similarly, the lobbies, you're going to see the signs on the floors to kind of stay that 2 meters, 6 feet apart. We're trying to move into more what we call passless check-ins, so that the amount of time you've got to actually spend, as Dr. Copeland said, waiting or in somebody's airspace will be different. You will see our receptionist, he or she should be wearing also a mask in this regard, whether it's surgical and or cloth. And then again, symptom checking all along the line. Our goal is, of course, as you said, is not to impede our patient care, but to try to make sure that we mitigate and have a safe environment as we move forward, and to continue to improve upon this. And hopefully, as you said, overlay some of the other tools now in our quiver about virtual, distant, telephone, so that we can actually be a little bit more nimble in hopefully serving our patients' need without that synchronous face-to-face.
And let us not forget hand washing, hand washing, hand washing. I've had to buy a lot more lotion for my hands with the alcohol and all of that. So, and patients, we're encouraging them when they enter our spaces and leave our spaces to also do that. So this is, I think the hospital is a new space. It's a healthy and safe space. We want to receive patients so that they can do well. This is what we're about. I'm going to ask a quick question of Dr. Gordon at this time. Did social distancing work for Ohio? Was it the right thing to do?
So another great question. I think, we were fortunate in Ohio for two reasons. One, not being on the coast, we were not necessarily the point of introduction of a lot of initial COVID cases before it was identified. As those that have been to Cleveland, Our airport is not exactly an international hub. You got to kind of want to get to Cleveland to get to Cleveland. The second thing is, I think Amy Acton and Governor DeWine were actually out in front in terms of actually closing schools quickly. Shutting down bars before St. Patrick's Day in Ohio is a big deal. Spending political capital, that was done. And really looking at the essential workers. And as you said, if you looked at cell phone traffic as a proxy for what people were doing, many people, obviously in the Midwest, stood down, and they know that. And I think that in and of itself saved more lives and prevented more infections than anything else that was done. And so that's on the people of Ohio. But with, as Dr. Copeland said, education, decision-making. It was not easy. And again, you cannot have people shelter at home forever. We know that. And now we've got to get more creative, I think, in terms of track and tracing, in terms of really hunting the virus as it spreads in households to keep this down until we get to that point of protection, hopefully through vaccine and not through just a spread of natural infections.
I'm going to ask you a couple more questions. I'm going to have you to give me about a 20-second answer for these. What types of trials are happening at the Cleveland Clinic? What can we expect to come from the research here and also with those abroad?
So I think the good news is we do have what looks like to be a effective treatment in terms of an antiviral, a drug called remdesivir. It's not a home run, but the initial trials and studies have shown that it decreases hospitalizations. These are for sick patients with pneumonia. No effect on mortality yet, but it is a drug now that is widely available throughout the United States, and we're using it. There's other drug studies that have been done, and those are to be determined. Supportive care is still the most important care for our sickest patients. And then, of course, a lot of focus on vaccine development. And there are at least 2 or 3 candidates that are moving to what we'd say phase 3 trials. So over the next month or two, tens of thousands of people across the world are going to get shots in arm, some placebo, some not. And so we do think that we will have good vaccine candidates probably looking at 2021. Healthcare providers, probably military and high-risk patients will probably be the first to be queued up in delivery. So we're very, very excited about that. But again, that's still a long, relatively long way off. We've got a cold and flu season we're going to have to endure before that.
Right. And we all know that we have to get a test. To get the test, we need to see a physician for an order. I'm very curious, like there's home pregnancy tests now that used to be only through a doctor's office. Where's the saliva testing? How close are we to just get the saliva or spit test, as we call it? If you could just quickly let us know.
I think what I call frictionless access to testing is very important in terms of control. And what we want to do is take it out of the prescription hands, to be honest. The saliva test is being evaluated. It sounds great, but to be honest, it requires a lot of saliva still being validated. But I think what is more interesting and probably is what we call the self-administered swabs. So if you go to CVS, or this is what you're doing, you get the kit, they watch you, you put it back in a box, and then they mail it. This is something we're trying to validate here, because if you think about it, Linda, if your patients can pick up a box, go at home and do it, we're not talking about the brain biopsy type, these are swirling, that this is a platform that can really, I think, take some of the barriers about testing that are still present for our patients.
Excellent. And I'd like to ask the last 2 questions for each of you, but for Dr. Copeland, I want to thank you for sharing your story. How were you able to maintain your resilience and stamina during this time? What were some of your strategies?
Some of my strategies were when I felt the chest pain, I felt tired and fatigued. I had muscle aches that kept me in the bed. I decided in my mind I need to get up. This is my body trying to shelter down and become more susceptible to the virus spreading through my lungs. I need to get up so that it doesn't have that opportunity. So in my mind, I just decided it's time to fight and get moving. Even though my body doesn't want to move, I need to get up and move. And also the support of my family. My husband was very supportive. He was the one making the runs up and down the stairs to bring me food to my door. And I had a supportive sisterhood that made food for me. So I had a lot of great support. My in-laws that they live here. They helped me tremendously with getting meals for the family as well. And just phone calls when people found out that I had the virus, I was very transparent. So I needed support because nobody else knew anybody else at that point that had it. They didn't have a personal story to relate to. So they all chipped in and helped. And my best friend actually coordinated a parade for me.
I remember seeing
that was
that
very
on
supportive
Facebook.
for me.
Yeah, I saw that on Facebook.
Yeah, so the
Excellent.
parade was actually on the news.
Excellent, excellent.
So they supported me, and that actually gave me the wind beneath my wings to continue on.
Excellent. And I'm going to kind of summarize this. It sounds like, Steve, you've told us how to focus on the fundamentals: hand washing, cough etiquette, social distancing, and masking. So you've given us a great amount of information. And this has been a great discussion. So I'd like to just say, let me say a special thanks to you, Dr. Steve Gordon and Dr. Joy Copeland, for sharing your time. I know you're all busy. I want to thank our viewers for joining our program, and we hope that you've enjoyed our first session. And I'd like you to share this with your family and friends on social media. A copy of this session will be available on our website. I'd like you to stay tuned. We're going to be doing these programs every month. You'll go to our website and be able to find out more information. Have a safe summer, social distance, and may we soon be able to have times where we may all meet again together. This has been fantastic. Thank you so much.